Examination of cardiovascular system. Again comes inspection, palpation and auscultation except percussion. Percussion is not required in cardiovascular system unless there is pericardial effusion. Pericardial effusion means it is the collection of fluid in pericardial cavity which is present around your heart. So there are three layers of heart: pericardium, myocardium, endocardium. So pericardium has two layers, visceral and parietal, and there is a pericardial space. If there is abnormal collection of fluid in that pericardial space, then it is called pericardial effusion. If pericardial effusion is moderate to gross, then it will compress your heart, and that causes cardiac tamponade by compressing your heart. So unless there is suspicion of pericardial effusion, there is no role of percussion in cardiovascular system. So percussion usually not required, only inspection, palpation and auscultation that is important for cardiovascular system. So this is the surface marking of cardiovascular system. You have to examine the precordium. As we discussed in respiratory system, you have to do the examination of whole this chest. You have to examine whole this chest anteriorly as well as posteriorly. Means both lungs, right lung, left lung. This is anterior chest as well as posteriorly. So you have to examine, you have to inspect, you have to palpate, you have to percuss, you have to auscultate this whole part in respiratory system. But for cardiovascular system, you have to inspect, you have to palpate, you have to auscultate only this area. That is, this area is called as precordium. This area is called precordium. So it is the area of the chest wall which is overlying your heart. So this is your the position of heart. So area of the chest wall overlying your heart, that is called as precordium. So this is your precordial area which you have to examine for cardiovascular system. This is the surface marking of each area. See, this is mid-clavicular line, anterior axillary line. So here is the mitral area, that is fifth intercostal space on left side. This is pulmonary area in second intercostal space on left side. Here is aortic area again in second intercostal space on right side, and here is the tricuspid area at the lower edge of sternum. Tricuspid area present at the lower edge of sternum. See, this is tricuspid area, this is mitral area, means this is the position of your tricuspid wall, position of mitral wall, position of pulmonary wall, and this is the position of aortic wall. So while auscultating the heart, you have to auscultate all these four areas. You have to auscultate mitral area, you have to auscultate pulmonary area, auscultate aortic area, and auscultate tricuspid area. So in the fifth intercostal space on left side, this is lower end of sternum, second intercostal space on left side, second intercostal space on right side. So cardiovascular system examination that constitute heart and blood vessels, examination of vascular system, examination of precordium, the part of the anterior chest wall overlying the heart. Inspection, palpation, percussion only if there is suspicion of pericardial effusion, otherwise no need of percussion, and auscultation. The patient should be examined in recumbent position or in sitting position and good light. And patient should be exposed. You have to remove the cloths or ask the patient to remove the cloth for proper inspection, palpation and auscultation. So patient should be well exposed, good light, and in recumbent or sitting position, patient should be comfortable. So first inspection, see this is the position of patient, patient should lie comfortably, patient should be exposed. Now you just inspect this area, that is the precordial area. So in inspection, which are the points to be noted in inspection? The first point is whether apex impulse is visible or not, means any pulsation. Apex impulse means any visible pulsation in the precordial area. Apex impulse, the position of apex impulse is fifth intercostal space, half inch inside the mid-clavicular line. So we see the mid-clavicular line, if you draw here, then you have to count the intercostal spaces. Now how to count the intercostal spaces? First you have to palpate the sternal angle. First you have to palpate the sternal angle. This is the sternal angle. It is sternal angle is nothing but it is the joint of manubrium and sternum. Joint of manubrium and sternum. You first palpate sternal angle. Below the sternal angle there lies second intercostal space. So first you palpate sternal angle. Below that there is second intercostal space. Likewise you have to count the intercostal spaces. Second, third, fourth, fifth. So if any pulsation is visible in this precordial area, particularly in the fifth intercostal space on left side, that means it is the apical impulse. It is nothing but apical impulse. So including inspection of the precordium, first point noted is whether apical impulse is visible or not. Whether apical impulse is visible or not. If apical impulse is visible, write down apical impulse is visible and then its position. And then its position, whether it is in the fourth intercostal space, whether it is in the fifth intercostal space, whether it is in the sixth intercostal space. So normal position of apex impulse is fifth intercostal space, half inch inside the middle clavicular line. Apical impulse is nothing but it is the apex of left ventricle. It is the outermost, lowermost part of your left ventricle. So apical impulse is formed by apex of left ventricle. The normal position is fifth intercostal space, half inch inside the midclavicular line. Many times apical impulse is not visible, particularly if the chest wall is hairy and patient is obese, and in female patient because of breast. So it is not necessary that every patient you can visualize apical impulse. So many times apical impulse is not visible because of thick chest wall, because of obesity, because of hairy chest, and because of the breast in females. So if visible, write down visible. If not visible, write down apical impulse is not visible. Then your second point, after apical impulse, other abnormal pulsations, any dilated veins if visible over the chest. Any abnormal pulsations, any dilated veins. So apical impulse is formed by apex of the ventricle, it is the lowermost and outermost part. So see, for example, these are the dilated veins over the chest. See, engorged dilated veins over the chest. It is because of superior vena cava or inferior vena cava obstruction. Superior vena cava or inferior vena cava obstruction, you get dilated and engorged veins. So, position of apex impulse, any other abnormal positions, any dilated engorged veins from the precordium. That is in inspections. Palpation, now you have to palpate the apex impulse. You have to palpate the apex impulse. Second is you have to palpate murmur. If murmur is palpable, it is called as thrill. If murmur is palpable, it is called as thrill. Now, how it feels to your hand? Palpation means you have to keep your hand over the chest, over the precordial area. You have to feel something. Now, what is the feeling of that? It is nothing but it is feeling like a vibrating mobile. The feel is like a vibrating mobile. Vibrations which you can feel to your palm. Then it is called as feel. So palpable murmur is nothing but some abnormal vibrations which you feel to your hand, just like the vibrating mobile. Then it is called feel. So feel is nothing but it is a palpable murmur which you can feel to your hand if you keep your hand over the precordial area. Third point is parasternal view. So in palpation, three important points. Apex impulse you have to palpate, you have to localize, you have to write down its position. Palpable murmur, that is still present or not. Parasternal view, present or not. 3 points in palpation. So this is the way of palpating apical impulse. This is the way of palpating apical impulse. It is the outermost, lowermost palpable impulse located by the patient lie flat. If not felt, turn the patient to left side, then you feel. Then count the spaces starting from angle of Lewis, that is sternal angle. Below the sternal angle, start second intercostal space. So count the spaces starting from angle of Lewis, that is the sternal angle. Below that sternal angle, there is second intercostal space, then third, then fourth, then fifth. So once you feel apical impulse to your hand, means any pulsations. Once you feel the pulsations to your hand, you localize that pulsation and write down its position, in which intercostal space or in which line it is present. So first localize and then write down its position. So it is the palpation of apical impulse with your hand. See, this is the palpation of apical impulse. First you palpate. Once you feel the pulsation, you have to localize the pulsation. So localization is always by tip of finger. So you can localize the correct position of apical impulse with the help of tip of finger. So with the help of tip of finger, localize the apical impulse, its position in the fifth intercostal space, half inch inside the midclavicular line. So locating the apical impulse with the help of finger. So feeling is with the help of palm. You can keep your palm flat and then localize with the help of finger. So, which are the conditions in which apical impulse is shifted or apical impulse is not infused in the muscular space, it is shifted in 6, 7 intramuscular space. So, whenever there is dilatation of left ventricle, if your left ventricle dilates, then there occurs the shifting of apical impulse downward and outward. Shifting of apical impulse is downward and outward towards the axilla. So it may be infused in the muscular space or may not be. If there is dilatation present, it can be infused in the muscular space and towards the axilla, more towards the axilla. So shifting of apical impulse occurs in cases of left ventricular dilatation. In cases of left ventricular dilatation, it is displaced downward and outward towards the axilla. Now the palpable murmur. So that is about apical impulse, how to palpate, how to localize, and these are the conditions in which apical impulse is shifted. That is ventricular dilatation. Now second point in palpation is feel, palpable murmur, whether any murmur is palpable or not. So how you feel? You feel just like a vibrating mobile. So it is nothing but a palpable murmur, similar to mobile phone vibrating, and same areas like the balls. So here you can feel the feel in mitral area, in tricuspid area, in pulmonary area, aortic area. All four areas you have to check for feel. All four areas you have to check for feel. Mitral area, aortic area, pulmonary area, and tricuspid area. Now, this is the general rule of palm. What is the rule of palm? With the help of fingertips, you can localize apical impulse. Or with the fingers, first you palpate apical impulse, and with the tip of finger, you localize the apical impulse. So, fingers are for apical impulse, for palpation and for localization. This basis of fingers or this part is for palpation of thrill. So with the help of this part, the basis of fingers, this part is for palpation of thrill. So fingertips to feel the pulsation, base of fingers for thrills, and this base of hand for parasternal view. For parasternal view, you have to use this base of hand. So for parasternal view, you use base of hand. For thrill, you use bases of fingers, and fingertips for localization of apical impulse or other pulsations. So this is the general rule for palpation of cardiovascular system. See, this is the palpation of thrill. So you have to palpate mitral area, you have to palpate pulmonary area, you have to palpate aortic area, and you have to palpate tricuspid area. All four areas. This is the position of patient. You can keep your hand like this, and at the basis of fingers, whether you are feeling any vibration or not. If you are feeling any vibration, that means feel is present. If you are not feeling any vibration, that means feel is absent. So just write down whether feel is present or absent. So if not present, write down feel is absent. So this is the method of palpating feel. So assess for feels across all four organs. Feels are nothing but palpable murmur. Now about parasternal view. In palpation, apical impulse, thrill, and third point is parasternal view. Now what is this parasternal view? It is nothing but it is the lifting of precordium. Your hand is lifted by the precordium. Your hand is lifted. So it is the lifting of precordium due to right ventricular hypertrophy, and it is classically seen in mitral stenosis patient of mitral stenosis. Parasternal view is present. It is nothing but lifting of your hand because of right ventricular hypertrophy. It is because of lifting of precordium which lift your hand, and it is classically seen in right ventricular hypertrophy in mitral stenosis. So for parasternal view, as we discussed, you have to use the base of hand. So you have to keep your hand over the precordium like this. With the base of hand, you just keep over the chest of the patient, that is over the precordial area, and you see whether there is lifting of hand present or not. If your hand is lifted, that means parasternal view is present. If your hand is not lifted, that means parasternal view is absent. So this is the way of checking parasternal view, and observe whether your hand is lifted up or not. Always keep the base of hand over the pre-corded area, like that, base of hand, like this. So this is the way of checking presence of parasternal tube, presence of three, presence of parasternal tube, and the position of apical impulse. These are the 3 points in palpation. If present, write down present. If absent, write down absent. So parasternal tube always suggests right ventricular hypertrophy, and it is classically seen in patients of mitral stenosis. Now the auscultation. So inspection, palpation, and now third point is auscultation. No need to do percussion. So what is in auscultation? You have to auscultate your heart. That means you have to auscultate heart sounds. Auscultate heart means you have to auscultate heart sounds. So there are two heart sounds which are normally present. That is S1 and S2. So which are because of closure of mitral valve and aortic valve respectively. So closure of mitral and tricuspid valve, and closure of pulmonary and aortic valve. So S1 is due to closure of mitral and tricuspid valve, and S2 is mainly due to closure of aortic and pulmonary valves. So normally there are two heart sounds, S1, S2, because of closure of mitral and sigmoidal valve. S3 and S4, these are the additional heart sounds which are normally not present, but if additional heart sounds like S3 and S4 are present, then it is called as gallop rhythm, and which is classically seen in heart failure patients. So patient of congestive cardiac failure, patient of heart failure will always get extra heart sounds. Not only S1, S2, dub dub. S1, S2 means you can hear. If you keep the stethoscope over the mitral area, you have to keep the stethoscope over the mitral area and you have to auscultate, lub, dub, lub, dub. That means S1, S2, S1, S2. If you get additional heart sounds like S3, S4, it is called gallop rhythm, and it is suggestive that patient in heart failure. Patient in heart failure. Now second point you auscultate is presence of murmur. So first to auscultate the heart sounds, second to auscultate presence of murmur. Now what is this murmur? Murmur is nothing but it is the harsh turbulent sound. It is the harsh turbulent sound. Turbulent sound means the turbulence of the water, the sound of turbulence of water. It is just like the sound of turbulence of water. जसा water turbulence चा आवाज असतो तसा. So it is nothing but it is the harsh turbulent sound which is produced through turbulent flow of blood. It is produced due to turbulent flow of blood when passing through the narrowed opening of cardiac valves because of stenotic lesions. If cardiac valve area is narrowed, if mitral valve area is narrowed, if aortic valve area is narrowed, if tricuspid valve area is narrowed, if pulmonary valve area is narrowed, if the valvular area is narrowed, the blood has to pass through the narrowed passage. Your blood has to pass through narrow passage. If your blood is passing through the narrowed opening or narrowed passage, it will create a turbulence in the flow of blood. It will create turbulence in the flow of blood, and that turbulence produces turbulent sound, and that sound is called murmur. So murmur is produced if your blood flows through narrowed opening, or if a large volume of blood has to pass through normal opening. A very large volume of blood has to pass. Openings are normal, valvular area is normal, but there is a large blood volume which has to pass through that opening. Then that large blood volume can produce turbulence while passing, and that produce murmur. And that produce murmur. And such condition is seen in case of patient of severe anemia. There is a large volume of blood has to pass. In case of hepatotoxicosis, in case of AV malformations, in case of beriberi, and these conditions are called hyperdynamic conditions. Hepatotoxicosis, beriberi, severe anemia, these conditions are called hyperdynamic conditions because a large volume of blood has to pass through the valvular opening, and that can produce turbulence in the flow of blood, and that produce murmur, so it is a functional murmur. Such type of murmur is functional murmur. When blood is flowing through the narrowed opening because of stenotic lesions of the wall, it is pathological murmur. Then it is called pathological murmur. So murmur is produced, there are two mechanisms: if blood flowing through the narrowed opening, or if a large volume of blood flowing through normal opening. So it is nothing but it is a harsh turbulent sound produced due to turbulence in the flow of blood. That is called murmur. So murmur can be systolic, diastolic. Means whether turbulence is produced in systolic phase or turbulence is produced in diastolic phase, depending on that. And that again depends on the type of valvular lesion, whether it is a stenotic lesion or whether it is a regurgitation. So we will discuss it in detail in theory lecture also. While discussing the rheumatic heart diseases, while discussing ischemic heart diseases, we will discuss this mechanism in theory lectures. So just remember, in auscultation, you have to auscultate the presence of heart sound S1, S2. If additional heart sound present, it is called gyro rhythm, which is suggestive of heart failure. Second point is presence of murmur, whether there is any turbulent sound. Then it can be systolic and diastolic, but there is no need to identify whether it is systolic murmur or whether it is diastolic murmur. You just able to identify the presence of murmur. You just write down murmur is present. You just write down murmur is present. If present, if not present, murmur is not present. But there is no need to differentiate whether it is systolic or diastolic for you people. So presence of murmur and heart sounds, these are the 2 points in auscultation. So this completes your examination of cardiovascular system. So you have to keep the stethoscope over the mitral area and you have to auscultate the heart sounds and the presence of murmur. So this completes your examination of cardiovascular system. So this is your heart. So this is your heart. This is your superior vena cava. This is your inferior vena cava. This is the opening of superior vena cava, opening of inferior vena cava, which open into right atrium. This is your right atrium. Now, so this is your right atrium. This is your right ventricle. So this is the right ventricle. This is the pulmonary opening. This is the pulmonary opening. This is the tricuspid opening. In between atrium and ventricle, there is tricuspid opening. Then from ventricle and pulmonary trunk, there is pulmonary opening. So this is your arch of aorta. There are 3 branches at the arch of aorta. This is your arch of aorta. This is the pulmonary trunk. This is pulmonary trunk from right ventricle, and this is the pulmonary opening. This pulmonary trunk divided into right and left. There are 2 pulmonary arteries, right and left, from pulmonary trunk. So this is pulmonary artery. Now this is left atrium, where opens 4 pulmonary veins. In left atrium, opening of 4 pulmonary veins. So this is left atrium. Left atrium to left ventricle via the mitral wall. Atria to ventricle, there is mitral wall. Now this ventricle to aorta, there lies aortic. Here is the aortic wall. This is your aorta. So in between aorta and ventricle, there is aortic wall. In between ventricle and pulmonary trunk, there is pulmonary wall. This is pulmonary wall. This is aortic wall. Here is mitral. Here is tricuspid. Inferior vena cava, superior vena cava, arch of aorta and pulmonary trunk. Right atrium, left atrium, where 4 pulmonary veins open. Right ventricle, left ventricle. And then this is descending aorta. Ascending aorta, arch of aorta, and descending aorta. So this is your heart, anatomy of the heart in short. So this is completes your examination of cardiovascular system, inspection, palpation, and auscultation. In inspection, apical impulse visible or not, position of apical impulse, any abnormal pulsation, any abnormal dilated import veins. In palpation, palpate the apical impulse, localize the apical impulse, palpation of murmur, that is thin and parasternal tube. And in auscultation, hard sounds and murmur. So examination of cardiovascular system usually very short and very specific. Examination of respiratory system is quite lengthy and in detail. So for long case, you need the system examination of cardiovascular system and respiratory system, only 2 systems. And for short case, examination of abdominal system. So next time